My name is Catherine Holyfield, and I am the STS National Database Manager for Intermacs and Pedimacs. And I want to welcome everyone to the STS Intermacs and Pedimacs Quality Reporting webinar today. Today we are grateful to have Dr. Ryan Cantor and Maceo Clegette from the Kirkland Solutions, the Intermacs Data Warehouse, joining us today. And they are the team to ask about anything that you want to ask about in those wonderful reports that you receive. Also, I want to welcome from STS, we have Leanne Jones, who is the manager for the general thoracic and congenital heart surgery databases, and Carol Crone, who's the STS senior national database manager over all the databases. And most importantly, want to welcome from Kirkland Solutions, Patricia Potter, who's our nursing informatics manager and clinical affairs manager, along with Maceo Clegette and Dr. Ryan Cantor. So before we get into what Dr. Cantor and Maceo are going to present today regarding the reports, I just want to give you some updates. I want to let you know that 2024 AQO is going to be in person, and it's going to be in Nashville, Music City. So we'll have some more information regarding that coming out soon, and hope everyone can make it there. Do not believe Dr. Singletary is going to join us today, but we have the Kirkland Solutions team, as I've mentioned previously. And another update is our COVID-19 update that we've had for going on almost at least that we had for 3 years, the COVID-19 exception that we gave everyone an extra 30 days after the follow-up window. We're no longer doing that. That ended January 1st of 2024. So our visits, we're going back to our visits how they are, our follow-up visits, and they are on the web-based data entry platform. You can also find them in the user's guide. We do have options for televisits now other than in person. So patients, if they do have follow-ups and they're not in person and they are telehealth visits, and you do have that option in the web-based data entry platform to put that option there. So again, the COVID-19 extra 30-day date exception is no longer beginning January 1st, 2024. We are going back to the standard follow-up timeframe procedure. So thank you, everyone. And Dr. Cantor, I think we will get to you, and you can go ahead. I can stop sharing if you want to go ahead and share your slides, or Maceo, whoever's going to go first.
Sure, I'm happy to share my slides.
Okay, and just as a reminder, for all questions, please utilize the Q&A instead of the chat. I appreciate it. Thanks.
Hi, everyone. I'm Ryan Cantor. I head up the group that produces the quality assurance reports for Intermacs and Pedimacs, as well as the dashboard and web analytic tools. So any comments or questions on any of those topics you have along the way, feel free to start entering those in the QA section. And Catherine, to your point about Brandon, I think we should start inviting him to these meetings and kind of expanding the coverage to be the reporting and the dashboards.
Yeah.
As well. That'd be great.
Absolutely.
Yeah. And I have a few updates from him. I included this for this week.
Okay.
So what I have prepared are just kind of some top level stuff, and then we have a lot of room for questions. But I'm going to briefly go over the report edits that were just launched that went out in December. We have a few things that are on deck to go out in the next reports in March, so I'll go over that. And I have a few examples of things that we have on deck for discussion and, thinking through how to implement, but really getting feedback on how you're using the QA reports or dashboard or the analytic tools in the system would be extremely helpful, or even just ideas of what you wish you had access to that'll help you, providing the data for your quality initiatives will be really useful for our team as we lay out our goals for 2024. I have a couple comments on data quality and ideas that we're thinking about how to demonstrate the quality of the registry, and any questions at the end. So jumping right in, we had two kind of top level edits on the reports that went live this last quarter. And there are things we've been talking about for a while, and we finally got them in place and implemented. So the first one was we wanted to improve the comparison of your site versus the aggregate. Intermacs began collecting data, I think, in 2006. So until we made this edit, when we talked about the cumulative reports, it was comparing all of the data at your site to all of Intermacs and all of those historic devices as well. And so this improvement we made limits that comparison to start in the year when your site started entering in data into Intermacs. So the arbitrary example I gave here was if a site joined Intermacs and entered their first implant in 2019, then the cumulative report will now be limited to your center versus the aggregate starting in 2019. So that comparison will be more contemporary with the devices that your site has been entering. This will be, much more relevant to sites that have joined, more recently compared to sites that, were in it from the very beginning. Then the second edit that we made, and this is a pretty big conceptual one, was that before this edit, the prior device grouping of patients was any prior VAD reported on the pre-implant form. And primary patients was everybody that didn't have this. We updated this definition to use prior durable VAD. So now any patient that had a prior durable VAD will be excluded from the primary patient report and in their own report, but any patient that had a prior temporary device will be included in that primary patient's report. And I think that's more in line with how patients are being supported now and the increased use and temporary support over the years. Those patients will still be in the main report as long as their first Intermacs device didn't have a prior durable device. So those went out, those edits went out in December. And from the few research coordinators I've talked to along the way and that Patricia has talked to, it's been well received. But if you have any questions on these changes or need any more details, let us know. And I will mention that at the end of the report, it does have a list of the patient IDs that are included. So if you're curious about a specific patient, where their data falls out in the reporting, that is right at your fingertips, or, if you need our help determining that, just let us know. Okay, so we have one edit that we're working on now that will launch in March, and the next two slides cover that. It's expanding the way we report on device malfunction and what rates are included in the adverse event rate table. So right now we do report on the top level, device malfunction, device thrombus event, like that kind of combined event. We produce the rate for that, and we produce the rate for whether or not you select within that a device malfunction or a device thrombus. I'll actually jump to the next slide. So this is what our current reporting, looks like. We break it out between the top level device malfunction or pump thrombosis. This is overall Intermacs. This is a fake hospital. Well, we're going to dive into more detail and produce kind of the next level of response here. So on the device malfunction and pump thrombosis form, it has for the device malfunction whether or not it was major or minor, and then for both types of events, it has kind of its association. Is it patient related or device related? And so we're going to start incorporating this data in a new exhibit in the reports. This exhibit will be limited to implants and events reported since the end of 2021, because that's when this went live. So this exhibit will be most useful to look at in the recent year report versus the cumulative report. But it will have these additional lines. It'll have the rate for the major device malfunction, the rates for the minor device malfunction, and then the different associations as well. So that should go live and be ready in the next report that goes out. And if you have any questions on this, put them in the chat, or ideas of other adverse events. If you want us to dive into more granularity on any of those, that's always an option as well. Okay, so we have a couple of edit requests that both to the QA reports and to the dashboarding tool that we're not ready to schedule those edits yet. We're still talking amongst the data team as well as the SDS Intermacs leadership to really solidify the specifications. But I wanted to show you some examples of things that we're thinking about, and so you can know what we're working on and if that inspires other edits. So within the QA reports, there's been a request to break out the right heart failure by severity. And this was mentioned by a site who remembered that when right heart failure was reported in the zone section on the follow-up, one of the questions made it easy for us to see whether or not it was a major or minor, like the severity scale was in there. However, the right heart failure is now collected as an adverse event, and so we're reporting it in the rates section. And so we certainly can break that out into different types of right heart failure and the rates of those different types, but we need to know how to categorize that based on the data that's collected on that right heart failure form. And I think all the information there is necessary to categorize in different severity, but it's not as obvious on the programming side. So we need to make sure we get the right definitions from the right heart failure task force and the SDS Intermacs leadership. But that is on our radar to add. I talked with Brandon in terms of what are the upcoming edits to the dashboards. There's going to be several new filters that are added. I don't have the details of those today, but there are some new filters that will be added. There's talk of adding some type of right heart failure, short-term and longer-term right heart failure outcome on the events page. We've talked about kind of making some edits in how the readmission event is reported. In the QA reports, readmission accounting is limited to patients that had a discharge and then looked at who's readmitted within 30 days. The current exhibit in the dashboard is what is the patient percent and rate of readmission within 30 days of implant date. And so that exhibit might be of less utility until we expand it to 30 days beyond discharge. So that does change kind of the back end and how we handle the data. It makes the exhibit a little bit more complicated. So we're having to evaluate the best way to implement that in the data. We've also talked about, and this is more of like how we structure these tools, not really what the exhibits are, but like where you click on to get on them. We're thinking about within the dashboard, adding a tab that will take you directly to the Kaplan-Meier tool or the outcome analytic tool, which is really a better way, a more statistically appropriate way to analyze long-term outcomes. So if you're using the dashboard, you know there's a lot of 30-day, 90-day exhibits on there, and those kind of patient percents and rates are very useful for those short-term outcomes. But when you look at longer-term outcomes, what's happening at 1 year, 3 year, 5 years to your patients, you know, this time to event analysis is a really useful tool to do that. And you have access to it now, but we're not sure if everybody knows about it. So we just want to make that a little bit more obvious. So those are things we're thinking about. Like I said, be thinking about any additional questions or ideas you have. And I just have kind of one more topic, and Catherine, please feel free to jump in here. But, you know, we get a sense of the data quality and the amount of effort and the utility of all of the Intermacs data. We see, you know, most sites have really outstanding follow-up completion rates. But we're always kind of wanting to be sure that we can document it and, you know, provide evidence of this, you know, data quality in the system. And so one thing that in the back of my mind that I'm always wondering about is like, how do I know that all of the implants that should be entered are entered? Because if the initiation of a patient isn't started, you know, our data team has no way to know that. And I don't really know what the answer is here, but we're trying to brainstorm different ways to ensure that we really are getting all devices in the registry. We have some ideas from non-Intermacs and other registries that we work on in Curso, and you know, so I think that would be a useful conversation to have. And then I just wanted to reiterate kind of the importance of getting the study endpoint and, you know, all of the follow-ups that are accruing for a patient resolved. So as we're building out more and more of these quality measures, kind of knowing the last time that the patient was seen and that they were alive becomes increasingly important for those comparisons. And so we're going to start really targeting the 1 month and 3 month follow-up forms and identifying, are there any gaps in the data entry? You know, are we, you know, sure that patients that we see as alive and on support at those time points, you know, really haven't met a registry endpoint. And my initial sense from, you know, working with this data for, you know, over 10 years now is that, you know, Intermacs does this really well. We're just trying to produce all of the, you know, like reports and documentation on that as we expand our kind of quality metrics. So, you know, if anybody has any ideas or comments on these topics as well, you know, feel free to bring those up in the chat. I'd love to hear your thoughts, Catherine, on this topic as well.
Yes, thanks, Ryan. Thank you so much. I think that's a really good point, especially on this slide about data quality, when you're talking about the 30 and 90-day endpoints. I know that's one of the beautiful things about Intermacs is our long-term follow-up, because it's really gold data, because not many databases do long-term. They stop at 30 days. So, and as you know, we have patients that have been on devices for years and years and years. So I think that's really important. I know Emily's on the call today, and so for our audits, for those sites that are on the webinar today that have been audited, you know, we do a 90-day mortality check. And so I think we're going to add in a 30-day for this upcoming audits for that. So we'll start checking at 30 and 90 days for mortality. That's very important, Ryan, like you said, to get the endpoints in. And I frequently, sites will, have patients that have endpointed, but they'll forget to put them in, and then their follow-up forms will just keep stacking up and stacking up and stacking up. So that's another data quality issue right there. And that brings up the important factor of the not only the QA reports, but the data quality reports. Those reports are really are helpful for the audits, because most of the tables in what's missing in what's checked in the data quality reports is what's checked in the audits. And Patricia, I'd love to hear if you have any follow-up on that or anything else to say.
Yeah, I just wanted to add that if when you're looking at your patient, looking at the patient summary, if you do have that scenario of, for whatever reason, I don't know if the patient is lost to follow-up or why those follow-ups are stacking up, feel free to reach out to me and I can help you kind of clean that up and see how we can, stop that from happening. So that is always an option if you do have some patients that, for whatever reason, the follow-ups can't be completed.
Correct. And I think on the the other topic you mentioned on is ensuring that all devices are being entered into Intermacs and Pedimacs. I think that's really important for both of those databases. I know it differs vary with Pedimacs, and they're having devices, probably more devices in and out in a shorter period of time than Intermacs, but it's so important to capture all those devices, to have them implanted into the databases. And I guess we'll go ahead. I think there's a couple questions. We'll go ahead and get started in the questions and see what they have to say. This is a really good time because I say this at every time we have this reporting webinar. This is your chance to ask Ron and Maceo all these reporting questions or dashboard questions. So we'll go ahead and get started. Looks like the first question was today the first notification of the 30-day COVID extension ending? Yes, it was. We met, the Intermacs task force leadership met, and actually I just received word they wanted to go ahead and end it. So that is why you're being notified today, and we will definitely. I will talk to STS marketing and see if we can how we can get that out in the newsletter. So yes. And we have a webinar at the end of the month, and we'll also discuss it there that it's ending. The next question from Deborah is, how would the integrity check affect those sites like mine who must consent for the registry? Only patients who signed consent will be entered into the registry, and how would you plan for something like this? And so, Deborah, I guess you're asking, are you talking about integrity checks as in making sure all the devices are implanted, the durable devices? I mean, do you read that differently, Patricia? Oh no, she said yes, yes. So since your site is probably one of the few sites that still consent, because I know you're in California, and I think most of the sites that still require informed consent are in California. I know that is a challenge.
I have a couple of thoughts here.
Okay, go ahead, Ron.
So, I mean, it's a challenge because you can't ask the data in the registry the question, what's not in the registry? So at least in my mind, it's like coming up with some way external to the actual data entry to say, is what's expected there. I know, and I'm not proposing this currently, but I know in the past, we've been able to reconcile device counts with the, um, manufacturers, and it was actually astounding, like well over 90 or 95% of devices were actually captured in the registry. But it was really good to know that. Like that gave us a lot of confidence in the comparisons we were making there. I don't know if that's an option anymore, but something as simple as, annually confirming volume with the PI, or just having that kind of litmus test are we getting what we think here? Or like you mentioned, Catherine, um, expanding the audits to make sure that the the number expected is the number that we have within a certain window. These are all, just things I'm brainstorming now. So, Catherine, we'll have to figure out how SDS wants us to approach it. But certainly we'd have to consider that if the site is consenting patients, we only are talking about patients that are consented. So that has to be factored into it. And the same thing with like, if you have consent, you can withdraw consent. So if that ever happens at a site, there's an option to endpoint a patient withdrawing consent, and then we stop accruing follow-up for that patient, and we take that into consideration in the endpoint and follow-up time calculations. So, all of that comes into play.
Right. Yeah. Thanks,
Catherine.
Ryan. And go ahead, Patricia. Yeah.
I was just going to say I can take the next couple of questions if you
Okay.
want.
Yeah.
So Colleen is asking for the major minor device malfunction. Can you give examples of each? I'd like to mention this at my next VAD meeting report out. Sorry. So Colleen, are you asking what the definitions of major and minor are? Yes. Catherine, I'd have to pull up a form to look at it. Let me see here.
Yeah, I can pull it up. I'm happy to and share it on the screen. Let's see. Stop it real quick. Okay. You'll see my screen. Sorry about the scrolling.
Yes, we can.
There we go. So for the major and minor device malfunction, here would be the major. Patricia, can you see that?
Yes. So basically it would mean that the patient ended with death, hospitalization, a life-threatening event. The malfunction resulted in significant disability or incapacity, and requires an intervention to prevent impairment or further injury. And then essentially minor would just be none of this applied.
Right. It would
And
be in,
Colleen, if you wanted to look at it on a form, if you went into the device malfunction form and if you clicked on major, the criteria to fit major, all of this death, hospitalization, life-threatening events, all of that will populate and you would have to check what applied. But if you were to click on minor, none of that will populate. So you can kind of see the difference there too.
okay, thanks, Patricia.
All right, and then from Rosalind, wondering if the FAQ questions highlighted in yellow that were on the user guide Q3 2020 will be included in the upcoming user guide version. I keep both the Q3 2020 and version 6.1 version or 2023 open to reference as I input data. Specifically asking here because my site may be questioning our infection numbers compared to full registries counts. As an intervention, changes get counted as additional AEs, even if some same ongoing infection is occurring. So a couple of things, Rosalind. So we did just update at the end of Q4 2023. There should be a new updated FAQ guide listed. I think it's under Appendix P as in Paul. And then so when an infection is ongoing, it does not need to be re-entered if it's already been entered one time. I think that's what you're asking.
So, okay.
Did I miss any part of that, Catherine?
No, I don't think so.
Okay. Yeah, Rosalind, if you have further questions, go ahead just to put them in here and I can answer them. All right, Cindy, for an infection that worsens, does that get entered as a new AE or how would we handle that? So to say that an infection worsens, did the patient warrant a change in treatment? Did they need to change the antibiotics? Did it need to escalate from PO antibiotics to IV antibiotics? In that case, yes, if there was an escalation in treatment. Or if the treatment needed to change, if they weren't being treated with antibiotics and now they were, yes, it should be handled as a new infection.
For an infection sec, there's a new how to handle that. What are you leaning towards, Patricia?
For Rosalind's question, this was the FAQ version.
The intervention changes. So the intervention did change. So it went from oral to
Yes.
IV. Yeah, then you would
Yes,
enter it.
does. Yeah.
Yeah.
Yes.
Yeah. You would go ahead and enter it.
But going the other way, you know, if a patient has to come off of IV in order to be discharged home on oral, no. But this would be an escalation in treatment. They needed something a little bit stronger.
Right. Thanks, Rosalind.
What other questions does everybody have?
Oops, sorry about that. Oh, she said sure thing.
I thought of a clarification I could share that someone asked me last week on two of the exhibits in the QA report. So I'm happy to share my screen and provide that distinction to everyone. Maybe other folks have the same question. Is that okay, Catherine?
Yeah, while you're doing that, let's see. Deborah has a question about
Oh, yeah, sorry.
infection again.
Oh, yeah.
So let's go ahead, since we're on the infection, keep that going. Deborah said regarding infections, what if a patient has a chronic driveline infection and patient has to be hospitalized for increased pain and there's no change in bacteria treatment? Do we report this as a new infection? So you are saying, Deborah, that they are re-hospitalized again for this driveline infection?
That's how I'm reading it too.
Yeah, so that would be considered a new infection. Because you're escalating, because they are having to be re-hospitalized. Is that correct, Patricia?
Yes.
Okay. And then new abstractor for Intermacs regarding follow-ups. I've noticed that the same questions are asked for every follow-up. Is there a way to automatically pre-fill for the next follow-up if the patient has a history? No, I'm sorry, Carson. It's main thing is because the Intermacs leadership believes the patient's physicality's changed. Good, because that's how to good deal, Deborah. I knew you knew that, Deborah. I thought if treatment didn't change, would only enter hospitalization. Yeah, that's what we said, enter the hospitalization. Brooke Myers, would that escalation in treatment for an infection be considered the same infection if it takes place during one episode hospitalization? Or would that escalation in need for a new AE entry be more applicable for changes in outpatient management, or if a patient was rehospitalized and new infection management strategies are utilized? So you're talking about Brooke, would that escalation in treatment for an infection be considered the same infection if it takes place during one episode?
My thought is if it's takes place for the first part of the question, if it takes place during one episode or hospitalization. So if we're talking about driveline infections, so say patient's diagnosed with a driveline infection, is treated with IV antibiotics or an IND and a wound vac or something like that, then it clears up while the patient is still in the hospital and treatment stops, but then it starts again. That would be a new infection. If I'm understanding your question correctly for that first part. And yes, if the patient was rehospitalized and a new infection management strategies are utilized, yes, that should be entered as well. That would be a change in treatment.
Correct. Yes. Thanks, makes sense. For device malfunction is significant disability or incapacity include critical illness, myopathy, where the patient discharges to long term to LTAC.
So Cindy, are you saying that if the patient experiences a device malfunction and their device is obviously not supporting them well and they develop myopathy and have to be discharged to an LTAC? In my mind, yes, that's significant dysfunction of the device.
Yeah.
And then Anne said, so for any chronic infection, any change in treatment equals new infections that needs to be added as an event. Yes, any change in treatment.
And we have these in the FAQs documents. Good, thanks. Yeah, Ryan, if you want to go ahead and move to that exhibit you wanted to show, that'd be great. I'll stop sharing.
Okay, can you guys see my screen again?
Yes.
Okay, I had
Cindy,
a
we'll get to you again, I promise. Go ahead, Ryan.
well, I had a coordinator that asked me what was the difference between the percentages reported in 22A versus the percentages in 22C. And in my mind, also what is the more useful measure here. This is in the talking about adverse events here. So 22A is the patient percent experiencing each adverse event. So if we're talking about infection, it's how many patients at your hospital, how many events, and then the patient percent having that. This is a fake hospital that I'm showing here. So this hospital, 47% of their patients had an infection versus 53 in the Intermacs aggregate. And in my mind, this is the most useful for comparing yourself again, your site versus, you know, the number or patient percent in all of the aggregate, because it's a really transparent measure. 22C is actually an exhibit that we had removed, but apparently one or more sites was using this for something, so they asked us to put it back in, and we did. But this, while numerically is accurate, is probably yet less useful for you to compare your center to the aggregate. And this is looking at just the counts of an adverse event and the percentage of adverse events. So here at this hospital, they had 875 adverse events, and that takes up 12% of all of their adverse events total. And so that might be useful if you're trying to like quantify like what is the highest percentage of adverse events at my center, like what am I reporting the most of? But because that always has to add up to 100%, that comparison with the aggregate is less useful. So I would only use the, knowing that infections are 12% of hospital X's, adverse events. If that's useful, then, it's a numerically accurate number, but the comparison to all of Intermacs is probably less useful there. So I just wanted to make that clarification to everyone.
Thanks, Ryan. Thanks for clarifying that. I think we're going to go back, Patricia, because Cindy added to her question.
I think maybe I caused some confusion with what I said.
No, that's okay.
So Cindy, I was only saying that resulting in significant disability or incapacity. That's only applying to if there was a malfunction of the device, not any patient that is impaired or has an injury meets this. It's only applicable to the patients that are having a device malfunction. Okay, good. Sorry about that. What is the location of the FAQs? So Jane, do you know where we keep the here I can put it in the chat box?
Yeah, if you want to, that'd be great. Or you want me to show them on here?
Yeah, that works.
Yeah, I can do that. I'll show you, Jane, no problem. So I'll go ahead and share my screen again, and here, we'll go ahead and here's the AEs. We'll go ahead and go back. So you're gonna go under Intermacs appendices. And then if you just scroll down, I'll go really fast, I'll go slow. You'll see the Intermacs Users Guide and the
Catherine, I
what they
think you might
stated.
be looking at a different screen.
Oh,
We can
whoops,
see.
sorry.
Yeah, that's okay.
What are y'all looking at?
Your definitions.
Oh, still?
Mhm.
Okay. It didn't switch over. Let's see. How's that?
See the website now.
You see the appendices now?
Yes.
Okay, thank you. So if you just scroll down, I think you got the FAQs right here. There you go. The Intermacs FAQ Users Guide. And they're updated every quarter.
Yeah. And sometimes people will say, you know, I'll answer a question, I'll say, can you include this? So if you think it's something that probably a lot of other people have that same question. And if you'd like, I can include it in the next one. You just mention it to me.
Yeah. Is there anything else, Patricia, you want me to show them?
I don't think so.
Okay.
I think it's all
Okay.
there.
Let's see if there's any other questions that we have. Location, we've done that. Thank you. And okay, thanks. So if anyone else has any questions, we have a few more minutes, or we can give back about 10 minutes of your time today. Okay, it looks like that's it. So Dr. Cantor and Maceo and Patricia and John, thank you for joining from Kirkland Solutions. Thank you from STS, Carol Crone, Leanne Jones, and Emily Conrad. I really appreciate it. Thank you so much for your support. And thank you for the data coordinators for Intermacs and Pedimacs that have joined. I appreciate it. Our next webinar is actually going to be, let me pull that up. Our next webinar will actually be, let's see. Can y'all, hopefully y'all are seeing my slides. Our user group webinar is January 31st at 1 p.m. Central Time, and our next reporting webinar is not until April 18th. So January 31st at 1 p.m. Central will be our next user group webinar. So hope to see and hear from y'all then. And I hope y'all have a wonderful day, and thank you very much for joining.